Hello, everyone, and welcome to this audio podcast. This audio podcast as part of the Pathogenesis edition. This audio podcast as part of a Torpedo storm. This audio podcast as part of the storm Richter. This audio podcast as part of a storm robotics production. And this audio podcast will be a sort of a interlude, a sort of an interlude that links links the series, but also links into part of a subsequent audio podcast series under Storm Robotics production as well. So in this audio podcast interlude, a little bit around some published works around the science of nephrotoxicity, and at the same time, a part of this works had been part of a had been part of a sort of an audio podcast in a previous under a previous Storm Robotics production. However, as part of this series, I sort of reflection, but also a sort of again sort of a link to a link to a Storm Robotics production subsequent audio podcast series. So scientists, immunologists, and clinical specialists, clinical specialists, and those in sort of pathology, tend to collaborate best when there is a consensus in investigations of around transplantation among pediatric recipients or patients. Collaborations are also successful when there is a determination to ensure safe efficacy of immunosuppression therapy with reduced side effects, to identify the best sort of possible transplantation, and the best sort of transplant in around solid organ transplantation, and align to cross matching in line to tissue typing, and sort of and line to serology for pediatric sufferers, or pediatric recipients, and to allow sort of prolonged functional or prognoses. Serology laboratories focus on in amongst sort of cross matching and sort of paneling techniques, organized in laboratories. The important investigations for possible match include, for example, lymphocytotoxic investigations and mixed lymphocytotoxic culture tests, and both are forms of tissue typing, or both are forms of what have been referred to in aligned to sort of laboratory medicine, and specifically around immunohematology, or immunogenetics, but also hematology, and around hematology. where terminology, or the terminology is generally referred to as has been referred to as tissue typing in line to serology. A clone match a clone match can't or cannot be established unless the pediatric recipient, a pediatric recipient is a twin, and when for example isografts, is terminology that is linked to identical or twin to twin, twin to twin a twin to twin solid, or a twin to twin allograft, and where literature informs that where isografts allows a prognosis in around solid organ transplants for example more than sort of baseline, or at the sort of primitive at the primitive level, the prognoses at more than 20 years, owing to the fact that owing to the basis that the genetics excuse me, the genetics between one twin and another twin are identical, are identical, or where the genetics are very are similar. and so and so at the same time, donors such as live, thus from a living relative, and cadaveric a recipient, where a recipient receives donor from someone who is pronounced as for example brainstem dead, have also been retrospectively applicable. The major histocompatibility complex MHC and human leukocyte antigen LHA characteristics are not are not identical, except in live donors, and where there is a sort of a greater match, a greater sort of tissue typing, a greater tissue typing sort of cross match, sort of sorology and complex. Cadaveric transplants show the greatest risk, or at least historically in the literature, show the greatest risk of rejection of solid organ transplant rejection, solid organ transplant rejection, but at the same time can be a decent cross match if carefully selected for post transplant post transplant. A sibling to sibling donor where HLA, human leukocyte antigen complement, is similar should for example have 7 or more years prognoses, and with greater differences of MHC, major histocompatibility complex, and human leukocyte antigen characteristics between pediatric patients or recipients, the chance or probability of prolonged functioning solid organ transplant, in this context around renal transplantation, prognosis is reduced. Rejection of transplants occurs mainly through cytotoxic T cell effects, immunosuppression, and the probable nephrotoxic side effects. The nephrotoxic side effects also cause challenges. T cells aid in detection of antigens and destruction of renal allografts, and T helper cells aid in appropriate recognition of complexes. Thus, there will always be some form of rejection. So either there is so again, just to inform again, that the rejection is either on the side of immunosuppression, where immunosuppression is linked to for example, where immunosuppression is linked to a high probability of um, of uh, of um, high probability in around the toxicological profile around pharmacotherapy such as immunosuppression. And secondly, rejection can occur owing to, for example, the potential mismatches between transplant between donor and recipient, and context of again immunohematology and immunogenetics, and aligned to cross match and tissue typing laboratory investigations. So in around and in following sort of around donor and age matching. Now, age matching, the aspect around age matching was in literature, or had become sort of a basis in around transplantation, in around aspects of solid organ transplantation, in around the mid noughties, in the mid noughties or the 90s. So unlike other transplants or solid organ transplants, the kidney has sugar antigens articulated on the endothelial cells of blood vessels. And so if the donor recipient has a different blood group complex from recipient, the antibodies will result in what is referred as a type 2 hypersensitivity reaction in the renal allograft, and will cause an elimination of the transplant through cytotoxic T cells. Cytotoxic T cells in laboratory medicine, or pathology, is sort of terminology that can also be in regarding to T cells that are referred to as CD8 cytotoxic T cells, and then there's CD4. CD4 T cells are referred to as T helper cells. T helper cells aid in the acknowledgement of transplants of binding to explicit areas of the major histocompatibility complex, or MHC. And allografted recipients might also have some HLA through rejection of a preceding allograft. This applies most importantly, and to elaborate on this in some stringent aspects, in some stringent aspect, and thus to inform thus this applies specifically in pediatric recipients or patients who, for example, have had more than one transplant, and in pediatrics versus adult recipients and adult patients, where pediatrics unfortunately may, owing to the etiology of different for example, the varying forms of renal diseases, in pediatrics, and the etiology in around diagnoses. Patients or pediatric recipients can, or at least historically, and in literature, can have or may have, more than one solid organ transplant. A variety of renal illnesses with the major histocompatibility complex, or MHC. The first of these uh, to uh, to be illustrated was an association between the DR2 and the antiglomerular basement membrane. Um, uh, um, illustrated was illustrated as an association between the DR2 and antiglomerular basement membrane antiglomerular basement membrane disease, or AGBM. Subsequently, several different MHC alleles have been coupled with other renal diseases. Techniques for MHC, or major histocompatibility complex typing, or tissue typing, um, have been have seen advances in line to serology and laboratory investigations, from sort of a sero and from sort of the and from sort of primitive serological investigations, to, for example, more molecular based modalities. And so these examinations are frequently, or frequently sort of have been costly, and do not have and unfortunately at the same time do not have a place in everyday clinical practice. Complementary to the MHC, the major histocompatibility complex, several other genetic indicators that may be linked with a variety of renal diseases are being explored, or have been are being explored, but those but these are also currently solely have been of research intrigue. Research also informs at the same time that kidneys from older donors into young recipients, um, research also informs that kidneys from older donors into younger recipients should be avoided, and these kidneys should be given to age-matched recipients. There have been there have been cases in the literature where older recipients, older donors, donate to can donate to younger recipients, and historically in literature, again, there have been cases in around this. So now, a little bit in around immunosuppression and nephrotoxicity specifically. So transplant pharmacotherapy, uh, um, as advanced as advanced where new agents or new sort of pharmacotherapies have been investigated and approved for use, and solid organ transplant recipients depend on can depend sorry can be, for example, prescribed and administered multiple immunosuppressive drugs, given in combination to given in combination, where, for example, specialists may refer this as, for example, single pharmacotherapy, dual pharmacotherapy, or for example, triple pharmacotherapy, in context of regimen in context of regimen to recipients, and ultimately, where drugs are given, drugs in context of regimen are administered or prescribed in combination to ultimately preclude allograft rejection. At the same time, the recipients often require recipients often require other therapeutic agents to treat underlying illnesses or concurrent or concurrent sort of illnesses or diseases, or at least we're in literature. Again, we're in literature to prevent sort of diseases. So wherever a new medication is administered to those to patients in around solid organ transplants, the potential also exists for increasing or decreasing tissue concentrations. So tissue concentration means tissue concentration in context of immunosuppression, and in around the theme around nephrotoxicity refers to the sort of trough levels at which immunosuppression at which would be the appropriate trough level at which immunosuppression is a sort of targeted for to achieve an appropriate area under the curve, but also in around the appropriate applicable therapeutic window. Now, at the same time, this can lead to serious complications such as over immunosuppression and infection. Clinical immunosuppression has been sort of unfortunately plagued with maintaining a balance between rejection of a transplanted organ and complications of over immunosuppression, including again sort of infection, and where infection can be linked to malignancy. So scientists with clinicians sort of must understand the current immunosuppressive regimens and associated effects post-transplant. Whilst all transplant recipients or patients receive some form of immunosuppression, the combinations and choices increase as novel drugs are developed. And in the critical and acute settings, newly transplanted recipients or patients will likely receive what's been referred to as induction therapy to increase sort of allograft prognosis, and whilst preventing or reducing allograft rejection, or acute allograft rejection, or AAR episodes. An understanding of the mechanism or the mechanistics of action and additive effects of drug also allows professionals to sort of optimize therapies or treatments or regimens with decreasing adverse effects. Immunosuppressive therapy offers a potential for reducing detrimental patient outcomes and improving allograft survival. Medication has been one of the major medications or pharmacotherapies. Pharmacotherapies have been one of the major concerns in around nephrology and renal medicine in context of transplantation, and has become more complex as more drugs are introduced or have been introduced into nephrology. In particular, anti-rejection therapy for again pediatric recipients. But at the same time, because of nephrotoxic substances enhanced in one's immune complex, there is a concern of secondary illnesses, for example, vascular complications in fact, sorry, sorry, there there is a concern of secondary illnesses. So again, for example, vascular complications, and impedes or pediatrics in young people with different forms of different forms of renal disease, the vasculature in line also to the lymphatics or the lymph in around the lymphatic system is where impedes in pediatrics versus adults diagnosed, and where for example diagnoses could be similar in some regard. So for example, a common a sort of applicable condition in peds and in adults in line to in around renal failure. Renal failure generally is something that's referred to as a condition referred to as, for example, nephrotic syndrome, where there can be a sort of a compromise to the functional components of renal pathophysiology. However, at the same time, the vasculature in peds versus adults in adult recipients can be compromised owing to the complexities around the anatomy sort of side of things. And so, in both disciplines of renal around renal medicine and pediatrics and adults, the patient or recipient can be treated sufficiently, sufficiently. However, in the pediatric in the pediatric recipient, at the same time, it is a challenge or difficult for treatment to aid a child's lifestyle, because tests and investigations can be more frequent, and thus also interfering with schooling and academic performance. At the same time, specific medications for pediatric recipients have many or can have many toxicological properties that affect the well-being that affect the well-being. And during the past decade, if not a little over a decade, several new potent immunosuppressive uh, uh, a- agents um, the, the, uh, immunosuppressive agents immunosuppressive agents with different modes of action and different side effect profiles have become sort of available through pharmaceutical industries and into pediatric nephrology specialties into pediatric nephrology specialties. Immunosuppression post renal transplantation is generally no longer a one single is no longer a one single regimen applicable to all patients or recipients. In the selection of optimal immunosuppression protocol, individual drug related toxicity, recipient related risk factors, as well as donor organ characteristics have been considered. Hopefully, at the same time where this where published works give should give an should give should give researchers and investigators and listeners and listeners in on this audio podcast, for example, a sort of a basis in around some of the the effects, some of the effects in context of some of the some of the aspects in around the toxicological profile of specific, or if not specific, at least particular kinds of immunosuppressive regimens. And at the same time, all immunosuppressants have different modes of action and efficacy surrounding safety profiles, and so scientists prompt the appropriate therapeutic indices to be prescribed by clinicians, so that there is a reduced toxicity impact in pediatric renal recipients. The pharmacokinetics of older immunosuppressive drugs, including, for example, cyclosporin A, CSA, or tacrolimus, or FK506, and mycophenolate mofetil, or MMF, and sirolimus or rapamycin, for example, are complex, but also at the same time, but also at the same time, ironically, quite comparable. A narrow therapeutic index unique to each recipient, as well as variable absorption, distribution, and elimination, are characteristics of these immunosuppressants. And TDM, or therapeutic drug monitoring, plays a fundamental role in helping clinicians maintain blood and plasma levels. Variations in concentrations outside the narrow therapeutic ranges or reference ranges can result in adverse clinical outcomes. The TDM also ensures that concentrations are not too high or not too low. High performance, in line to sort of laboratory medicine investigation that has been used have been used in around by laboratory professionals or specialists to guide clinical practices, is an investigation referred to as high performance liquid chromatography, or HPLC, and it is also used for TDM of mycophenolic acid and the active metabolite of mycophenolate mofetil. TDM of tacrolimus has also been improved, has advanced with the development of varying laboratory assays with greater sensitivity for specificity for tacrolimus than those previously available. It is important to identify a specific pharmacokinetic parameter for each individual drug, whether it is trough levels or the area under a concentration time curve, which may be almost useful, which may be most useful as a tool for optimal TDM or therapeutic drug monitoring in routine scientific practices. TDM guidelines help also to ensure quality assurance and safe, effective practice towards transplanted recipients. All immunosuppression is associated with drug-related nephrotoxicity or impaired renal function. Despite advances in immunosuppression, major improvements in treatments have been required, especially in a reduction in around the toxicological profile and sort of sort of the rigorous definition of the association or relationship between drug concentration and clinical effects. Such improvements are achievable with more second and third generation immunosuppressive regimens. Tacrolimus or FK506, mycophenolate mofetil, MMF, and sirolimus, as part of anti-rejection programs, and the development of rigorously defined therapeutics have generally been important. The preferred modality for renal replacement therapy, generally in literature has been documented or sort of docketed as solid organ transplantation or transplantation, and its superiority in prolonging the longevity of pediatric renal recipients, for example, with ESRD or end-stage renal disease, is also evidenced. So in terms of for example, well-being or where well-being leads into QOL or quality of life, pediatric surveys indicate that renal transplantation is better than other replacement therapies. That being said, at the same time, there is little literature out there that sort of compares and contrasts the forms of renal replacement therapy, renal replacement therapy, where literature has not really looked at sort of for and against in context of pediatric in around a pediatric specialty. And so, in sort of summary to this, during the past decade, several new potent immunosuppressive agents with different modes of action and different side effects, side effect profiles have become available, have become available in line to pediatric nephrology specialties, but also in line to in around solid organ transplantation, immunosuppression post-transplant is no longer a sort of one single and applicable, and again, a regimen applicable to all patients. One single regimen, again, applicable to all patients or recipients. And so, at the same time, minimizing immunosuppression induced nephrotoxicity improves allograft survival. However, to obtain single long-term improvement in allografted recipients or allograft outcomes, it may be necessary to adopt new immunosuppressive regimens. Challenges facing biomedical and clinical scientists and clinicians should now be focusing on addressing, for example, at the same time, equality, educational support, and the burden of disease post-transplant as well. That draws this interlude to a close. This has been an audio podcast as part of a pathogenesis edition, an audio podcast as part of a torpedo storm, an audio podcast as part of the storm Richter, an audio podcast as part of a Storm Robotics production. Thank you.